This is a compilation of the Recurrent Shoulder Dislocation series that I recently concluded. It goes into a fair amount of detail. So if you're interested in learning about shoulder dislocations in general, please watch on. But if it's only specific parts that you're after, feel free to use the timestamps to skip to those parts. Right, let's get on with the video. I'm sure you've heard of people who dislocate their shoulders all the time, and you might even be one of them yourself. So, what actually happens and what actually contributes to the stability of a normal shoulder? The shoulder is a ball and socket joint. Now, the first component that contributes to stability is simply the fact that the ball is somewhat cradled within the socket. The second component is a ring of cartilage attached to the rim of the socket. Now, this cartilaginous ring is known as the labrum. The labrum is in turn attached to a ligament that spans the ball and the socket, holding them both together. The last component is a sleeve of tendons known as the rotator cuff. Now, the rotator cuff is attached to the arm bone and it pulls the ball firmly against the socket. So together, these three components maintain stability. Now, if any of these components fail, the shoulder may be rendered unstable. Let's talk about bony morphology. Now, the shoulder joint is a ball and a socket joint. Imagine that the base of this can is the socket and the ball of the arm bone sits in it. Now, the slight concavity of the socket gives it some stability and the ball doesn't fall off too easily. Now, imagine that there is a shoulder dislocation and it knocks off the lip of the socket. The joint is now unstable and the ball falls off a lot more easily. Next, imagine that this is a normal shoulder joint. If the ball dislocates, it slams into the edge of the socket, it might cause a dent to form at the back of the ball. So in future, as the ball rotates within the joint, if the dent gets caught on the edge of the socket, it might make the joint dislocate more easily. And that's how injuries causing changes to the bony morphology can result in shoulder instability. So let's talk about the labrum today. So this is a plastic model of a shoulder joint. This is the socket, also known as the glenoid, and this is the ball, also known as the humeral head. They fit together like this. But you notice that it is actually very easy for the humeral head to slide off the glenoid, and the reason for that is because the glenoid is naturally a very shallow structure. So there's a ring of cartilage that is attached to the rim of the socket, and this ring of cartilage is also known as the labrum. It looks something like this. So the labrum actually just deepens the socket a little bit, so that it makes it just that little bit harder for the ball to jump over and dislocate. However, when a dislocation does occur, oftentimes the labrum is torn off the rim of the glenoid, and this then renders the shoulder joint unstable and it predisposes the patient to future dislocations. The rotator cuff is a bunch of 4 muscles together with their tendons. 1, 2, 3, and 4. They originate from the shoulder blade, cross the shoulder joint, and attach to the humerus. During shoulder movements, the rotator cuff contracts and pulls the humeral head firmly against the glenoid, stabilizing the joint. Arguably, the rotator cuff is the least important structure in terms of maintenance of shoulder stability, but it does not mean that it is an unimportant structure. In older patients, I'm talking patients in their 40s, 50s, and beyond, shoulder dislocations can result in rotator cuff tears. Rotator cuff tears will then exacerbate the problem of shoulder instability, which may eventually result in the formation of a special type of arthritis known as cuff tear arthropathy. Often, a first dislocation results in a tear of the labrum at the front of the glenoid, also known as a Bankart lesion, and a dent at the back of the humeral head, also known as a Hill-Sachs defect. Now, these lesions often do not heal and can cause recurrent shoulder dislocations in the future. They can be fixed via keyhole surgery. Let's talk about repairing the labrum first. As discussed in my earlier video, when a labral tear occurs, the labrum is actually ripped off the bony rim of the socket. The labrum is a soft tissue and I can easily place stitches around it. However, I cannot stitch bone, so in order to reattach the labrum, I have to use implants known as suture anchors. The concept is simple. The suture anchors are inserted into the bone and used to securely hold the sutures that were stitched through the torn labrum. Over the course of a few months, the labrum then heals back onto the glenoid. The problem with a large Hill-Sachs defect is as the arm rotates, the edge of the glenoid might fall into the defect, causing the shoulder to dislocate. Bone is not malleable like metal, so it's not like we can simply hammer out the dent. So what we do is a procedure known as Remplissage. Remember earlier on I spoke about the rotator cuff, which is a tendon that crosses the shoulder joint. Now imagine this yellow ribbon represents the rotator cuff. In a Remplissage procedure, the overlying tendon is rerouted into the Hill-Sachs defect and fixed in place using suture anchors. So when the patient rotates the arm, the Hill-Sachs lesion is prevented from engaging the glenoid edge, reducing the chances of a redislocation. Finally, I'm going to show you how a Bankart repair with Hill-Sachs Remplissage is done. Have a look. So I usually start off by taking a look around. There's the Bankart lesion, and there's a pretty extensive Hill-Sachs lesion over there. I start off with the Hill-Sachs, and that's the first anchor going in, the second anchor going in, and then I turn my attention to the Bankart lesion. There's the first stitch going in, the first anchor, cut the suture, and done with the first one. Repeat the same process for the second one. There's the anchor going in, cut to the suture, and the last one, the last stitch going in here, the last anchor going in, cut the stitch, and that's done with the Bankart lesion. Pretty simple. Now I turn my attention back to the Hill-Sachs, and as I tighten my suture, you can see that the tendon is being rerouted right into the Hill-Sachs lesion. And if you look into both the head and the socket, you can see that the head is nicely centered. We've spoken about how Bankart lesions and Hill-Sachs defects can be treated, but what about if there's a big bony defect involving the glenoid? In such cases, a bony procedure known as a Latarjet procedure will be required. There is a nubbing of bone known as a coracoid process found at the front of the scapula. In a Latarjet procedure, the coracoid process is cut, then transferred to the front of the glenoid and fixed in place with screws. This surgery is highly effective in preventing future dislocations, but it is also often a very difficult surgery to do, and it carries an estimated rate of surgical risk in excess of 30%. Hence, I always treat Latarjet procedures with a lot of respect. If we remove the humeral head and look at the glenoid end-on, you will see that the glenoid is a pear-shaped structure. Now, if a dislocation knocks off a part of the glenoid, it would narrow the glenoid, making it much easier for the humeral head to dislocate. So in a Latarjet procedure, this part of the shoulder blade, called the coracoid process, is cut, then transferred to the glenoid and fixed in place. Not only does this widen the glenoid, making it harder for the humeral head to pop out, but arguably more importantly, when the arm is put in a vulnerable position like this, a tendon that remains attached to the transferred coracoid forms a restraint across the front of the joint, almost like a safety strap, further preventing the humeral head from dislocating. The Latarjet procedure has a success rate of up to 99%, and patients can resume upper limb sports about 3 to 4 months after the surgery. And that concludes the video. I hope it's been useful. I put out videos discussing various orthopedic conditions regularly, so do check out my social media accounts. I'm Dr. Bryan. I'll see you in my next video.